Have to unmute myself. There you go. All right. Hello, everybody. Welcome back. Nice to see familiar faces again. I was just telling Hem at the beginning of this that how much I have enjoyed this series, and I look forward to, potentially doing other series with the OLLI program. So please let Hema know if you have enjoyed these. I assume that you have if you've come back. So that's always a good sign, I think, initially, right? If I was bad, you would have left after the first one. So thank you very much for everything. And I know, as you know, or at least those of you who have been with me before on other talks, is that if you have questions, please ask them throughout. And if you want, of course, I'll save time for questions and answers at the end. But I'd love to be able to have a bit of, again, a dialogue. I'm much better presenting that way. And again, I feel that everybody learns better that way as well. So, so today we're doing a talk, which actually I don't give this talk this often. So it's really nice. People don't ask for this. And I think it's a really great talk. So I might be biased, but I still think that it's a nice talk, and it's a really great world of expanding this word of dementia, and to see what else is it besides just Alzheimer's disease. So as most of you know, I am here on behalf of the Alzheimer's Research Center at UCLA, the Easton Center. And we are one of 10 state designated California Alzheimer's disease centers. And I am the co-director of the training and education activities for that. So love being able to do these presentations as on behalf of the Easton Center, so that you find out about our services, as well as just providing the basic education, which is one of our core fundamentals as being a CADC, really just focusing on education. So today we're going to talk about the different types of dementia. So we're going to just do definition of dementia, and I've picked three, the three most common non-Alzheimer's types of dementias. We will get into these with some pretty good detail. And so we're going to talk about frontal temporal dementia, also known as FTD, Lewy body dementia, also known as LBD, and then vascular dementia. So just initially, I want to talk about this word, and those of you who have come to my presentations before, I know you have seen this slide, but it's very applicable to this presentation. Just again, using the word dementia. What is this word? And what does it mean? So the word dementia is a word that describes a group of symptoms. And so, and it's in these two areas where you have to have cognitive decline as well as a functional impairment. So you have to have a cognitive decline in one of these five modalities, either thinking, language, memory, judgment, or reasoning, as well as a functional impairment. So in terms of, let's say, if you're thinking, you're having thinking problems that are new, that have come on board, that have come on either gradually or quickly, and that now you're having a hard time taking medications, or you're having a hard time driving. We see this often, not because somebody admits that they're having a hard time driving. It's that a family member may come and see the car, and you realize the car has a few new dents to it, some new paint colors, typically yellow, of a pole or something like that on the side of the car. Like, okay, well, what's happening? Like, well, I'm still able to drive. Yes, you're still able to drive. They still have the ability to drive. They're just not doing it safely. And there is an impairment that is causing that. So it has to be both of these. You can't just have language problems and have it not affect your day-to-day life and call it dementia. And it's important to know that this is, again, not a normal part of aging. This is not something that you should just anticipate. And if this does happen to you or to a loved one, then that is an area where you need to raise a flag and bring this person to a physician to get some help and to be able to address these issues. So when we think about the causes of dementia, the ones I'm going to talk about today, they're more what we call neurodegenerative. So this is where there's actually a decline, a degeneration in the brain. The neuro is brain, degeneration. And so we're going to talk about Alzheimer's disease, as I said, Lewy body, Parkinson's dementia, as well as frontal temporal dementia. There's also a type of dementia that is not as what we call neurodegenerative. It is vascular dementia. And so just for a quick example, neurodegenerative, Alzheimer's disease, and I know I said I wasn't going to talk about it, but you can't have a dementia class and not talk about Alzheimer's. It just doesn't happen that way. Upon autopsy, a person with Alzheimer's disease, their brain is 1/3 the size of a normal healthy brain. So it actually shrinks, and it does what they call neurodegenerate, where this degeneration occurs where the brain cells die and the brain actually shrinks. So that happens with Alzheimer's, Lewy body dementia, Parkinson's, and frontal temporal. It does not happen with vascular dementia. Vascular dementia, it's more of an issue with the blood flow that's going to the brain. And I'll talk about that a little bit more as well. There's also traumatic brain injury that could cause a dementia. Again, that is more of a one-time event, and that causes damage. It's not that it's going to get worse over time. They may just have this damage that has happened to the brain, and that is where they are now at. That is now their new normal. And then there's also what we call infectious causes of dementia. This other type of dementia is called Kreutzfeld disease. It's essentially like the human variant of mad cow, where it is what they call a prion disease, where these prions are actually infectious. So if somebody has Kreutzfeld, or as they also call it, CJD, if they realize this in a surgery room, that room has to get shut down, scrubbed head to toe. The whole wing of the whole area of the hospital really needs to be cleaned up so that this does not spread. We actually had a family friend of ours quite a number of years ago who had CJD, and it was, no one knew what it was. This was before I was in this field, and just shocking at how quick his decline was. Essentially from onset of any symptoms to death was about 8 months. And it was such a quick, rapid decline that by the time he was actually even able to get in to see a neurologist, he had progressed so much. So that is definitely much more of a rare case of dementia. And then the other type of dementia that I'm not going to talk about today, I know I've talked about it in some of the previous classes, is more of a reversible dementia. So this is where it could be because of depression, a thyroid problem, malnutrition, medication interactions, where it's causing this cognitive loss and a functional impairment. But once the medications get fixed, or once the thyroid problem gets treated, then they can go back to what their normal baseline would be. So these are the different sort of categories of dementias. So what causes dementia? A whole bunch of things causes it. So here's the umbrella. I know if you've come to the other talks, you have seen this slide. But again, explaining that fact that that dementia is this umbrella, underneath it, there's all these different types of diseases or syndromes that cause the dementia type symptoms. So obviously Alzheimer's is going to be your most common form, which is why we are not talking about it today. So the first type that I am going to talk about is frontal temporal degeneration, also known as FTD. So frontal temporal dementia is the second most common form of, again, a neurodegenerative, where the brain cells actually die and the brain actually does get smaller for people under the age of 65. So while you look at this, this is a different population. The symptoms are very different with FTD. So if we're looking at this as FTD, it's typical age range of onset is between the ages of 40 and 80. So yes, that is that's a large age range. But when you look at it as being the second most common form of people under the age of 65, is really where you see the large numbers of how this disease can affect people. It is an insidious onset, gradual progression. And then people live, 2 to 10 years up with this. There are different types of FTD, and this is what's really interesting. So this is all from the University of San Francisco. They have a great FTD program. The other site website that's sourced on this page is theaftd.org. that stands for the Association of Frontal Temporal Dementias.org. So like there's the Alzheimer's Association. This is an FTD specific organization that helps with education and information about this type of dementia. So this is actually, it's really interesting because there's these different subtypes of FTD. So you have a behavioral variant. And again, I'll talk about each of these in more details. And then there's language variants. So I think Alzheimer's, when people diagnose, it's just like, here you go, you label it, it's one kind. But some of these others, especially FTD, can really break down into different subtypes and different types of variants. So the behavioral variant, which I'll talk about next, there's also the language ones, semantic primary progressive aphasia, and then non-fluent primary progressive aphasia. So again, different types. So the behavioral variant, this one, years ago, so one of my first jobs was working at an Alzheimer's care facility, or was an assisted living / Alzheimer's care facility. And, new, fresh out of college at that point, hadn't even entered grad school yet. And, I was helping doing the activities, for this place. And there's a woman there who had FTD. It was my first encounter with it. I knew nothing of it beforehand. And this woman was just what I would call fascinating. She was younger. She was probably, again, early 60s. So for a care facility, you're definitely younger. And she could talk to you about current events. She could talk to you about what's happening in the news. But she would go around the dining room and go up to other people's plates and take their food. And the other residents would get so mad at her because what is she doing? Or she'd go up to somebody and just get right up into your face, like realize there's no personal space and just ask questions, almost like invasive questions. Or if she would see something there, she would take a sip of someone else's cup. And just this very bizarre behavioral problems. And once I learned a little bit more about this, you realize, okay, so that she had what they call the behavioral variant of frontal temporal dementia. Some of the big symptoms of this, the first signs is this disinhibition. There's a woman who is part of one of our support groups. We have an FTD caregiver support group. And she tells the story of once her and her husband were at the Hollywood Bowl and they had a box seats. So there was like 2 people in the front and 2 people in the back in the box seats. And her husband was in the front 2 seats, and she was in the back and like they're with their friends. And her husband reached over to the next box, these other people who they didn't know who they were, and took some of their dessert. And it was just, she's mortified at this because like, okay, we don't know these people. You don't do that, right? You ask and he just went over and took it. And she's mortified. Luckily, she was behind, so she was able to tell the people, hey, he's not well, he has this disease, it causes this kind of behaviors. And they ultimately were fine with it. But you think about that kind of a stress on a family member, never knowing what your loved one is going to do because they have this disinhibition. They also develop an apathy where they lose interest in work. They lose interest in hobbies, even if they're still employed. Like my boss had a patient once who when he first came into her clinic for a diagnosis, the family was saying that he just decided to stop going to work. And it wasn't, I don't like my job. It was just, no, I don't want to go in. And he would go golfing instead. And yes, lots of people would joke about that. It's like, oh yeah, I'd rather go golfing than go to work too, right? But it was just this, he didn't even think that there was something wrong with this decision. It just was. It was, he just didn't want to go anymore. And it was just like, in his mind, it was fine to make that kind of a decision. And there wouldn't be any other effects on a decision like that. They also, people with FTD, behavioral variant, really start to, they develop a lot of repetitive behaviors, just compulsive, like hoarding, repetition of words, hand washing. Some people do just like a basic clapping all the time. They repeat just some of these behaviors that, again, you're not sure about, like, this is different, right? This is odd. What is wrong? They develop a lack of empathy. One of the big examples is where if you tell somebody who has FTD, hey, your wife died, they'd be like, oh, okay. And that's it. They wouldn't have that sadness, or, we had to put the dog down. Okay, when's lunch? It's like they would process the information, but they wouldn't show any of that outside empathy. And you think, again, for the world of the caregiver, how challenging that would be. The impulsivity that comes along with FTD, where they want to do something, they want to do it. That's it. There's no rhyme, reason, explanation, anything along those lines. And then they also have lots of diet changes, binge eating, lots of sweets. Sometimes people with the behavioral variant of FTD will actually die on like asphyxiation because they just put so much food in their mouth at one time. And it's really sad. There was I think it was another 60 Minutes episode that they did something on FTD, and you see how these people have changed from this form of dementia. So if you're thinking about an average age of onset, a 58-year-old, probably still working, probably at the point of, maybe still providing for some sort of a family, and thinking of these types of symptoms that come about. So very different than if you're thinking of somebody with Alzheimer's disease, 88 years old, and what those different lifestyles would be, as well as the effects of it. Again, it's different from Alzheimer's in the world of the prominent behavioral changes, and the memory is actually still there, and the visual spatial skills are still there. So they could talk about news, they could talk about what to have for dinner. They can have these conversations that people with Alzheimer's can't. But they also, if they're hot and if they're outside, they may take off all their clothes because they're hot. Okay, I'm hot, let me just take this off. And you think about like those types of challenges, and that won't often happen with somebody with Alzheimer's disease. The semantic variant of frontal temporal dementia, and it lasts about on average 6 years, where people start presenting with what they think or what they would classify as a memory problem, because they're forgetting words and concepts, but it's much more of an identification problem. It's much more of a being able to identify this. It's like they just say, well, it's a, as opposed to saying, well, it's a pen. They don't have that ability to truly identify it, or if we had, see, if we were in person, I'd be able to do this a little bit easier. If we had, let's see here, what do I have at my desk here? Okay, so if we have this and this, if I asked you, what are these? You should be able to identify stapler and pen. But a person with semantic variant FTD may just say, well, it's the thing that you use, where they don't have that ability. Or if I tell them what, they may call one of these a fork. And it's not that they actually think it's a fork, it's just that's the word that's coming to their mind or coming out. So it's very different. Again, you think about this world of identification and how someone's going to think that it's a memory problem, because if you can't remember that this is a stapler, well, then you must be forgetful. But it's not that easy. It's not a matter of being forgetful. It's about not being able to identify it. The semantic variant also can come with a loss of a facial recognition, where they can't identify people's faces anymore. Reading difficulties. Again, for example, on the slide here, it says reading the word kernel, not as, and again, the English language is terrible when you think about these things, and like it doesn't necessarily make sense. It would be like colonel as opposed to kernel, where this is a word that we read it as kernel, but they don't have that ability anymore. Again, diet changes happen. And then they also get into another very rigid routine. This is what it must be, and this is what it must be at all times. If it's not like this, then they're going to get upset. So then there's the non-fluent variant of frontal temporal dementia. Again, average duration is about 6 years, and more problems with word finding difficulties. Again, thinking non-fluent. This is all have to do with verbal skills, where there's more of a difficulty in speech. It's more of it takes a lot to get out the word to identify this. well, they can't get the actual word out. It's they can understand, and you can say, okay, well, Pearlie, this is a stapler. And, then Pearlie would be able to take it and know what it would be, what to do with it, but she wouldn't be able to identify it. And she wouldn't be able to use those words, but she'd be able to comprehend. People with this variant often progress to mutism, where they just don't speak anymore. And then they also may develop other features, such as some Parkinsonisms, which we'll talk about later. And then they have some of the behavioral problems that are similar to the behavioral variant of frontal temporal dementia. Any questions? I was talking to my son before this presentation. He's 12, and I was telling him what the talk was, and he said, "Oh, Mommy, that sounds very interesting." I said, "It is. It's a lot of information." So it's one of those that it's a lot of information for processing. So I want to give you the space for that. And so if anyone have any questions, I think, did I hear somebody go off? If so, just unmute and then just ask. Or not.
So far, no questions.
Okay. I thought I heard something. So just,
I have a question.
Oh, yes. There we go.
Yeah, I
Linda.
do. Yeah, hi. Monica, in your slides, you give an average duration, and in this one says 6 years. So what happens after the average duration?
Thank you for asking. That's a very good question. Ultimately, they pass away. These are all causes of death because of the way that they impact the brain. So it isn't just that somebody that's actually a really great question. Thank you. And I should edit the slide to be a little bit more clear on that. Like I say, I don't give this presentation often, so thank you. I'm very happy you asked that. Yeah, it is often a matter of the person passes away at the end. Yeah, Pearlie, I see your hand up.
Yes, Monica, I have a couple of questions actually. You give the year range, like usually this is older people, think about older people. How young can some of these happen? Because, I mean, and can it be as young as childhood? Some kids that are in school that may have been misdiagnosed because of some of the symptoms. I see a lot of symptoms here that could be, just say, misdiagnosed as depression for, pretty much all ages. So could you kind of expound on that?
Yeah, of course. So any of these diseases that I'm talking about today are all adult. They're all adult onset. Of course, there could be very rare, 1 in millions cases. I think we all always have to give space for that. But this is a matter of essentially anything after the age of 45 for the most part. So this would not be something that would be diagnosed in children. If so, there'd be a much greater issue or greater problem. So, and then when we talk about, so the age range, especially for FTD, since it's the second most common form of dementia for people under the age of 65. So this is most likely going to affect people who are younger. And between that, we mean like 45 to 65 for the most part. Of course, there are people who are diagnosed later, and there might be people diagnosed earlier, but roughly in that age range.
Thank you.
Does that answer your question, Pearlie?
Yes, it does. There was one category about traumatic, something that comes about a bump on the head where there's a temporary loss of memory and different things like that. How does that play into this?
So that would be more of, let's say, a traumatic brain injury. So I'm not going to talk about that type of dementia so much because it all depends upon where the brain injury occurs in terms of the brain. But let's say if that was someone who was in a car accident, it's not just a bump, or it would be repeated concussions. So like we hear a lot about football players with the chronic traumatic encephaly, the CTE, that would be another version of a dementia. And so that would be something through a traumatic brain injury. So sometimes it's a one-time brain injury. Sometimes it would be a continued concussions or continued injury to the brain.
Thank you.
All right. So now, so let's see, just to show you just a few images, because I always think these are cool to be able to get into the brain a little bit to see the difference, to see how things are affected. So we're looking at frontal temporal dementia. So these are the MRIs, and you look at where they're going, where a clinician is going to look to be able to identify this as FTD versus Alzheimer's disease would be the atrophy or the shrinkage of the brain in the frontal area, the frontal lobe. So it's this part in red that's highlighted up on the top slide. Look at the difference again. For this other one where it's facing us, we're looking at the atrophy on the right versus the atrophy on the left. So you see how there's more black and less white. And so that's actually showing a shrinkage of the brain, showing that there's more space there. And so this is where they would most likely diagnose with FTD. Again, semantic dementia, they're going to show, again, different parts of the brain. So that's why, you know, when we talk about like traumatic brain injuries, you know, all these different parts of the brain do something different. So it all depends upon where an injury took place. But in terms of FTD, the MRI is really one of the best images or imaging techniques that you can do, just because it shows the atrophy that has occurred. If this wasn't there, it wouldn't be FTD, and they'd have to figure out why do these behaviors, or what is causing these behaviors if it's not this atrophy in the frontal part of the brain. Again, this is a PET scan image. I always think that it's neat to show these just so that you can get the idea of what's happening in the brain. Again, we're looking at the frontal region of the brain right about here, where you're seeing the, oh, hold on, I've got to get off my pointer here so I can actually, so I can move all of you so I can show my other image. So again, we're looking at the image, the reduction of activity in the brain in these frontal regions, which is able to be seen through the PET scan. So when we think about basic pathology, so this is much more of the scientific part, which I will not get into, but I do like to mention it, of frontal temporal dementia, there's the behavioral variant, which is, these are both usually what we call tauopathies, as opposed to the amyloid plaque that is the hallmark of Alzheimer's disease. So this is an accumulation of this tau, and then also what is known as a ubiquitin tau. These are both different types of proteins that just accumulate in the brain. Seeing how they are different. There's a woman in one of our groups, her adult son has FTD, and her son's father, her ex-husband, had it. And it is a very rare strain that they were able to identify that there is a genetic component to it. And so when you think about 60% of FTD is actually sporadic, but 40% can actually be purely genetic family history, which is much stronger than Alzheimer's disease. And so where you look at this world of 15 to 40% actually have an inherited identifiable gene. So this is one of those diseases that there is more of the research in terms of genetic traits and genetic predisposition to this disease. Currently, there are no actual FDA-approved medications specifically for FTD, but what they have is they have symptom management. They do SSRIs often to be able to help with any sort of apathy, irritability, or disinhibition, antidepressants, and then also some antipsychotics for if somebody gets very agitated. But they always say to use these cautiously because of the effects that the antipsychotics can actually have on the brain. Makes sense? Clear as mud, right? Everyone's got this down, FTD, right? Okay. I think I've overwhelmed Janice. Okay, so, and any questions on FTD before I move on to another type? All right, if you do, please feel free, ask questions away, ask away. So the next most common type of dementia that we're going to talk about is dementia with Lewy bodies. So dementia with Lewy body is the second most common form of dementia after Alzheimer's for people after the age of 65. So FTD is is second most common before 65. Lewy body dementia, DLB, is after 65. Again, it's another neurodegenerative disease. People can present with similar presentations to Alzheimer's disease, and it's often missed in terms of diagnosis. When I was doing some additional research for this, trying to find some of the generic websites to see what kind of information they put out. And someone was saying, well, best place to go for a diagnosis is your primary care physician. And I actually I chuckled to myself, because most primary care physicians, they have heard of DLB, but they don't have the ability to diagnose it. It's much more complex. So that's where we say the referrals to a neurologist is really what is best for the person with the dementia. So when we, dementia with Lewy body, again, roughly around 65 years old, if not over, when somebody is diagnosed. The range is 50 to 85, but they're most often diagnosed after the age of 65. The duration, and again, after they go through these years of it, they do pass away from Lewy body dementia. Average range is 5 to 7 years. Sometimes it could be 2 to 20. So it's very similar to Alzheimer's in that effect, and that really, and that aspect in terms of the length of time that somebody could have this disease. It affects men a little bit more than women, and there's about 1 million people in the United States with it. So when you think about it, it's not a rare dementia, it's just less common. So this is the dementia that ultimately was discovered that Robin Williams had. And after they did the autopsy on him and they discovered Lewy body dementia, I think it really brought this dementia out into the forefront a bit. People starting to hear about it. It was no longer something that was just sort of hidden. And lots of that is just because of people not being diagnosed. And there is limited support for the caregivers of people with Lewy body. We at the Easton Center, we run a virtual now, and it's going to remain virtual support group for loved ones who have family members with Lewy body dementia. And we're the only one in all of LA County. So there isn't another group. So at first we would meet in Santa Monica on a Tuesday night. And well, I guarantee not many people like coming to Santa Monica on a Tuesday evening with 405 traffic, 10 traffic, 110 traffic. So now that it's virtual, we are reaching people from San Diego to Santa Barbara to Inland Empire who are able to be a part of this group. So finding that support is really wonderful. With the DLB, age is going to be a greater risk factor. A family member with the DLB is also going to increase your risk. And then I know if you've come to some of my earlier talks, we've talked about this APOE4, which is a gene that is often closely related to Alzheimer's disease. It's also a gene that is related a bit to Lewy body dementia. So somebody initially, upon clinical presentation, they come into the doctor's office, and these are often the complaints that would allow us to be able to diagnose someone with Lewy body dementia. More of a gradual progression of cognitive changes. Again, there is memory loss that is associated with this, a lot more so than FTD. But there's loss of that executive functioning, that ability to really plan and to focus the executive tasks that we do. Also, there's an inability to understand visual information. So that changes as well, as long as memory. And people with Lewy body, what's so interesting with this dementia is that, let's say someone with Alzheimer's, they sort of go into like this world of, they have a new phase. Let's say they aren't able to communicate, or they're not really that with it or be able to converse. But people with the DLB will go in and out. So they'll truly have what we call good days. And then they'll have days that are just really bad, where they aren't able to really be alert or to have any orientation to time and place. But the next day they can say, okay, so it's Tuesday, March the 29th, and I'm right there. So you wonder, it's this real fluidity in terms of their alertness. One of the big hallmarks of Lewy body dementia is these visual hallucinations. And these are often non-threatening hallucinations. They're often hallucinations of animals or children, sometimes people, but they're very real. They're real hallucinations. It's not the guitar comes to life. It's look at all of those ants that are crawling across the floor. Oh, look at that little girl over there in the green polka dot dress, where these are truly very well-formed hallucinations. And, you know, this one gentleman who, the wife is in our support group, and she said they were sitting up watching TV one night and her husband was just there falling asleep on the couch, just falling. She's like, honey, just go to bed. Like, what are you doing? Why are you staying up? You're falling asleep. Just go to sleep. He's like, I can't go to sleep because those men are here. And it would be rude if I went to bed when we still had guests over. And there were no men in the house. So this visual hallucinations of these men, they just were. So the wife told him, you know, you go to bed, I'll just entertain them and I will explain to them that you just aren't feeling well. You go to sleep. And he did. It was just sort of matter of fact. And so that's the difference between these hallucinations also being delusions, or where they could be threatening hallucinations. People with Lewy body dementia will also develop what we call a Parkinsonism. So, you know, if you think about someone with Parkinson's disease, there's lots of more shuffle. You can't see my hands, like a shuffling of gait. And a person with Lewy body dementia will have these Parkinsonisms where they may take a while to go grab that glass of water. You know, there's the pen here, and they don't just go like this. It's more of this hesitation to get to it, even though their mind, they're telling it to go, but their body just isn't following. They're at a really increased fall risk because of the shuffling that can occur with their, because of shuffling of the feet, because of this Parkinsonisms. They have definite disturbed sleep behaviors. Again, this is one of those first areas. Looking at all of these things is what can help the neurologist make the proper diagnosis. Is because these sleep behaviors, it's to the point where it's starting to affect their partner. Where it's like they say maybe the partner's legs are covered in bruises, and it's because their loved one is kicking them at night, or the caregiver, the partner, has now gone to sleep in another room because of the thrashing that is occurring at night. And so that these are actually some of the presentations that would allow a clinician to be able to diagnose this as Lewy body as opposed to something else. Depression obviously is going to come in. It's going to come to play with all types of dementias, and then also some forms of delusions as well. So one of the things with Lewy body dementia that would really, because people with Parkinson's disease in the later stages, they could develop a dementia. So it's, well, which came first, the chicken or the egg? Is this Lewy body or is this Parkinson's related dementia? And the key definition is this timing of the symptoms. So for people with Lewy body dementia, their dementia type symptoms occur at the same time or at least a year before the onset of the Parkinsonisms. So they're going to have these visual hallucinations. They're going to have the sleep disturbances. They're going to have those types of things before the physical changes. So it's more of a cognitive change before physical. If someone has Parkinson's disease, they're going to develop the physical changes first. And then maybe later they would go on, as it says, 50 to 80% of Parkinson's patients go on to develop some form of a dementia, but that would be later into the disease. Any questions? Okay. So when we think about the pathology of a Lewy body dementia, we're again looking at these hallmark features, which are Lewy bodies and Lewy neurites. Of course, this was first discovered by a researcher named Dr. Lewy. As with all of these diseases, they're named after the person who first identified these. And then there's also this accumulation of this alpha-synuclein, which is, again, it's common in lots of different types of dementias, but really it's the placement of this alpha-synuclein, which would have it be different than other types of dementias. Medications for Lewy body dementia. So Lewy body dementia is one of those, again, there's no actual medications specifically FDA approved for Lewy body, but they would do the same type of pulling from Alzheimer's disease medications. So for any cognitive symptoms. So those are what they call the cholinesterase inhibitors, or your Namenda, your Exelon. And then there's, oh no, not Namenda, I'm sorry, your Exelon, your Aricept. And then there's another classification of drugs of your Namenda. So that would be more for your cognitive symptoms. And then for movement symptoms, they would prescribe Parkinson's medications. The area of real needing to be cautious with Lewy body dementia is the world of the hallucinations. People with Lewy body really should not be prescribed some of the antipsychotics. They can make the symptoms worse. So again, the reason why getting the correct diagnosis is so crucial is so that these symptoms don't get exacerbated because of the medications that they are on. Janice, you unmuted. Do you have a question?
Yeah, I do. How many, who often is the first one to recognize that there might be a dementia problem? Is it going to be the patient, or the one who has the dementia symptoms, or is it usually going to be the spouse or significant other or family?
Yeah, it depends upon all of it. Sometimes we actually, so in terms of these dementias like Lewy body and FTD, I think that's most often it's the family member, and even the same true for Alzheimer's disease, because again, it's a disease. These are diseases of the brain. So sometimes people don't have the insight to be able to realize that these changes are happening. But there are, a number of people that we hear, that we talk to, who have Alzheimer's disease, who they're the ones that first mention, like, hey, I'm not right. Like, I've been in a cloud. There's something wrong. I need some help. Let's try to figure out what this is. Again, that insight doesn't happen to everybody. It'd be great if it did, because then it would actually really be beneficial. But it is often family members who would be the first ones to put up the red flag on this, say, let's go and get some sort of an evaluation.
Yeah. Okay. Thanks.
Any other questions? Okay. So Lewy body dementia, again, I find it's fascinating. I think all of these are, again, I'm sort of this dementia nerd where I like all of these things. I think it's neat to see the way the brain works and how different it is for everybody, and how it can be so unique for everyone. And each case by case situation is very different as well. Then this other type of dementia, vascular dementia. So this, again, another more common form. If you've heard of my other presentations, I have mentioned in reference to vascular dementia, based upon, it's the one that we really know that we could do the most to prevent or reduce our risk the greatest. So vascular accounts for about 10 to 30% of all dementia patients, third most common form. And it's very common after a stroke. Not like, yes, if it's a big stroke, there's going to be some dementia, but it's also sometimes it's the very small strokes that build up over time, where you don't realize that someone is having these little TIAs, but they're occurring. And then it's a slow, gradual progression after that. So this is where we see, again, it depends upon where in the brain these little mini strokes are happening. We know that these mini strokes and strokes can happen all throughout the brain. So it depends upon where that occurred to see what the clinical presentation is going to be. And again, varying pathological patterns, varying time courses. This one I think has the most questions around it in terms of being able to tell people what's next. Because some people could develop vascular dementia after a stroke, and then they could never progress from there. They could just sort of stay on this trajectory, just like, okay, I'm now here. But then let's say if they have another stroke, they could do a sharp decline, but then they balance out again. And then maybe if they have another stroke, they'd do another sharp decline, and then they balance out. Some people will just do a very slow, gradual decline, all based upon, it could be these mini TIAs are happening, or just not enough blood getting to the brain. And so that's why when we think about vascular dementia, we're talking about controlling for our risk factors, hypertension, diabetes, obesity, making sure that we take care of our bodies to take care of our brains, and really to make sure that you get the oxygen rich blood to your brain all the time, by exercise, cardiovascular exercise, and really getting that heart rate up. About half of people with vascular dementia have probably some sort of a mixed vascular and Alzheimer's disease. My grandmother had Alzheimer's disease, or at least when she was diagnosed, that's what she was diagnosed with. But I now, knowing what I know, and she was diagnosed back in the 90s, realizing that she probably had a mixture of Alzheimer's and vascular because she had had a significant stroke that caused the initial cognitive impairments. So we see how lots of people have a mixed dementia as well. And vascular dementia is probably the one that's most likely mixed in with others. Again, risk factors, we're going to look at age, hypertension, diabetes, prior strokes, smoking, again, this ApoE4 gene that we have talked about. It is a risk factor. It is not predictive. So you could get tested for it, you could have it, and you could go on and never develop dementia. So it's not predictive. It is just a risk factor. And this is sort of what I was talking about already. Sometimes I get ahead of myself so in terms of my slides here. So if we're thinking about the clinical spectrum of vascular dementia, it could be these three different areas where one, it's a sudden onset with an immediate cognitive decline. Right away, you notice, okay, someone has to go to PT. They have to figure this out. They might get back, they may not. Other people may have multiple TIAs, like I mentioned, where it's that stepwise decline. And then some have more of this insidious onset, where it's a gradual decline, and where it's not cut and dry in terms of what will happen next or how it will happen. And again, all depends upon where in the brain is where the vascular disease is taking place. And wow, okay, I got to my last slide. I did that faster than I thought. It's 2:22. We still have time for questions. Okay, great. Okay, so this is my information again. I know I've given this to you for those who have been to the other talks, but if you have questions, shoot me an email. I'll be happy to be able to help with any questions that you might have. So, or either now or if you think about it later. So I'm going to open up the chat to see if there's any questions in there. Oh, thank you, Hema. Hema just put my email address in the chat as well. So does anyone have any questions?
I do.
Janice?
This is more, it's kind of related to last week's talk about clinical trials. So I pretty much trust the data from clinical trials research, but often I'll read something, like recently I read people who have gum disease are more likely to get dementia, or people who eat nuts are not, and those don't feel like they're as well researched as clinical trials. I don't know if they're more causation as opposed to correlation. So I don't know how to judge the quality of those things.
Oh, it is so hard. Honest. Oh my gosh, Janice, especially being in my position, I have people at presentations who will say, so I read about the study that said how champagne helps prevent Alzheimer's. And I'm like, I don't know what that study is, but I'm happy to support the efforts of that one. But there's so many different theories that come about. The one about gum disease, though, I do know about that one. So that is much more correlation related, because people who have gum disease are more likely to have less access to medical care. And so it's this world of, if you have less access to medical care, you're going to have an increased risk of dementia because you're not taking care of hypertension, diabetes, blood pressure, all of those other factors that we've talked, those cardiovascular factors. Also, again, socioeconomic factors really do play a role into all of this in terms of, we look at this world of health disparities across the board. And it's interesting, the research that they've done, realizing people who have more gum disease do have an increased risk of dementia. But I think that that's much more of that correlation. So it is so difficult. It is so difficult to understand what is true and what is not. Whenever people ask me about something, I'm just like, if you could send me that article, I'd love to take a look at it. I'd love to try to get some more information to see where's the research that's behind this? Because you hear of studies too that are like, so 10 people, like, well, I don't know about these 10 people. Like, okay, well, what kind of, how reflective is that upon other things? So it really is, especially in this field, there's so many things that we hear about. And even for a long time, they were talking about, you remember, like aluminum was bad,
Oh,
right?
yeah.
Like, oh, no, don't do aluminum pots and pans, aluminum foil. And then
Lewy
they've realized,
Bodies,
yeah, oh yeah, deodorant, But
Yeah.
then they've realized it's not that people with Alzheimer's have an increased, that it's the aluminum that they've absorbed from pots and pans. It's just aluminum is a natural element in our environment. It's on the periodic table of elements. Yeah. And how people with Alzheimer's, it seems like they can't process out the aluminum in the same way that people who don't have this decline do. So again, what is it? Is it the plaques and the tangles in the brain that clump things up so things can't get out? So that's where like the aluminum theory came up. Years ago, it was vitamin E. You got to take vitamin E, take but then they did clinical trials with people with large amounts of vitamin E, and they had to stop those trials because of such severe side effects, lots of bleeding issues for people. So, I think lots of these things that there's a tinge of truth in them, but enough where it's a matter of being able to open it up for further research as opposed to banking everything and getting rid of all of your aluminum pots and pans.
Okay.
I see Myra, you had your hand up first.
Yes.
You want to unmute? Yeah, go ahead.
My sister had dementia. She had vascular dementia, and the doctor said that it was caused by some prior like little strokes had happened, but they had happened probably 10 years before. So her decline was rather slow, but we didn't know for sure until we took the test where they asked you to spell things. And she would spell a word, but she would mix numbers with the letters. And that's when we knew for sure. But the question that I had was about the Sundown Syndrome or whatever, like 3 or 4 o'clock in the afternoon, when they kind of, is it like across the board with the dementias where people kind of get more into their symptoms in the afternoon?
Absolutely. Absolutely. Yeah. What it's called sundowners. And it happens. Some people never experience and some people do. It's much more of just a behavioral environmental thing that happens. It's often due to, again, as we're experiencing it now, the change in sunlight, the change of the days, how the sun really does, it matters a lot to our bodies and to our own circadian rhythms. And people with Alzheimer's disease and other forms of dementia will often have just confusion around that time of the day. Also thinking that they're probably tired. Mornings is when we're all better and we're sharper. And thank you, Hema. And then also realizing too, that this types of behavior symptoms, trying to figure out what it is, it's very challenging for caregivers for when people are experiencing it. But yeah, it happens sort of across the board, just with different variations based upon the diseases and how they present with their own symptoms. Pearlie, I see you have your hand up.
Yes, I just wanted to ask you, have you, well, my sister also, one of my sister has been diagnosed with dementia about maybe 2-3 years ago. She did have all the things that you mentioned related to maybe the TIAs. They found they called it old strokes they found when they did this on her. Also high blood pressure and some other things, that she's had. A pre-diabetic, she's not diabetic, yeah, right on the border there to be just about. So we're trying to watch all those things, but I want to ask if you had done any research on a drug called donepezil, which has been prescribed for her, I think maybe about a year ago. She's been a year ago, and it increases the dosage. And it seems to me, and we're watching her and she's doing other things, so it's hard to say what's doing, what's contributing, maybe everything, a little bit more exercise and more diet control and things like that. But do you do research on particular types of medicines? In this case, I'm concerned with the donepezil, which I'd never heard of, but I think she's doing okay. She's, and how she responds to things and all that.
Yeah, so at our center, we do not do research on any of the medications that are already FDA approved. So everything that we know is more just anecdotal, anything that we know just from what we have heard. Donepezil is one of the most common Alzheimer's or dementia type medications. It is used quite frequently. It does not slow down or reverse the dementia. It just helps with the symptoms. So let's say if we're thinking about structural changes to the brain that have occurred that have caused the dementia symptoms, those aren't going to go away because of the medication. But the medication can help her improve at a high or function at a higher level. So it would take away maybe some of the cloudiness, some of the confusion, and it does that for a little while. It's not a cure. She will still continue to progress. But combining that, especially with diet and exercise, are some of the best things that you could do, because it's not just a pill factor. You need everything to really get an optimal result off of any of these medications, as well as, again, with dementia, it's all brain related. So we want to keep your brain as healthy as possible for as long as possible. And that's keeping your body healthy as possible. So yeah, donepezil is something it's used quite often.
That's great. I just wanted to this is bugging me. I have to ask you about this because I know that this is maybe an old way. What was the purpose of doing those lobotomies? And I see that you have a picture of the brain where you can identify. What good would it be to cut out the front part of your head or something? That's ancient stuff.
Yeah, luckily they don't do that much anymore. The only time that's going to happen is if there's like a tumor and you need to get that tumor out. That world of thinking, luckily we have gotten past that.
Yeah.
And so, yes, obviously if there's something that's a lesion of some sort that can't be reduced by treatments, medication treatments. But even that, I think people don't want to go in there. Like I've always said that, it's your brain, right? It's fairly significant. It's not something I'm just going to sign up for. And again, brain surgeons are amazing people who are able to have that kind of fine the patients and not moving their hands. But for anything dementia related, unless it's a cancer or it's a tumor or something like that, they're not going to go in and do anything like that. Like the images that I show, those are scans, like an MRI where you go into the tube, or a PET scan. Again, it's more of the imaging techniques, as opposed to no one really wants to go in there. We want to make sure that we don't want to mess with that. It's like, it's just not something that we want to do.
Thank you.
So thank you, everyone. It's 2:34. So I know we have gone 4 minutes past our time. But thank you so much. And to those of you who have been with me for lots of these, I know Janice, you've been around, Susan, Pearlie, David, you've been around too for lots of these talks. So I appreciate you coming back. And again, if you have any questions, please feel free to reach out to me, send me an email, or if you know of other areas that I can come and speak, I'd be happy if you have other groups that you know of, church groups or other things that you're a part of. I'd love to be able to come out and do other presentations. It's all sort of a part of what I do. So
thank you very much.
yes, thank you. Thank you very much. And Hema, thank you so much. It's been a pleasure working with you. You are nice and you are easy and you are efficient. And I love working with people like that. So
thank you, Monica. Likewise to you. It's always a pleasure and can't wait to have you back here for the summer. Definitely follow up with you. And thank you everyone for being here. This concludes our session. Once again, I did provide the course evaluation here in the chat, so please go ahead and complete that for me. But other than that, thank you all. Thank you, Monica. I'll see you soon. I'll follow up with you in an email after the session.
Sounds wonderful. All right, everyone, take care. Be well.
Thank you, Monica. All right. I did provide the course evaluation link in the chat. I'll go ahead and put it again. Go ahead and click on that and complete that for me, please.
Okay.
If you have any questions regarding that, please let me know.
Where is the course evaluation?
It's in the chat.
It's in the chat.
in the
I just
chat.
clicked
Yeah.
onto it, right? I'm just clicking onto it. I don't see anything yet.
I don't see anything either.
I just put it in the chat again, in the chat room down in the bottom. If you mouse over and select chat, you will see the blue link there. Go ahead and click on that link, and it's going to open a new window.
Okay.
Is that it?
This evaluation. Right.
That's Monica Moore, right?
Yes, Monica Moore.
Where? I don't see it.
I went into a meet your new microwave edge, and I didn't have that last time. That's strange. It was strange. I'm sorry. Motion detected at the east side. I'm not getting it. Let me see. Let me see if I can go into another device.
And once you complete the survey, go ahead and click on submit. It's at the very bottom of the evaluation. And then you're good to go. Appreciate your feedback, everyone. Oh, Arlene. Okay, Arlene, can you stay a bit afterwards? I'm gonna try to see if I could get you the whole presentation. I see there in the chat, so I'll send it to you, Arlene. It's a link. You're gonna have to click on that link, and it's gonna open up a new tab.
Did you send it?
Yes, I did send it to you in the chat.
You sent it to me in the chat.
Yes, I see your response, so I replied back to your response in the chat.
I don't know why I don't see it.
That's okay, Arlene. If you don't see it, then perhaps I can email it to you separately.
Okay.
Okay.
I'll
And go ahead.
Should I give you my email address?
I believe I have it already. If you registered in this class, then I should have it. Let me see if I
Okay.
could.
All right. Thank you.
Thank you, Arlene. I'll go ahead and email that to you as soon as possible. I would appreciate your feedback.
Okay.
And welcome to our
And
class. I'm
also,
glad you were able to make it.
This was the last session, but I didn't see the sessions before this.
Okay. And I'm just curious, Arlene, how did you hear about our sessions?
If I could remember, I would tell you.
Okay, that's all right. I was just curious. I thought a friend probably referred you, or you saw it
Yeah.
through our email, through our catalog.
Also, I'm not living in Santa Monica right now, but I used to live in Santa Monica, and you see, so I had heard about your place at UCLA.
Okay. Okay. Oh, I see. Okay, got it. Okay, Arlene. Yeah, I have your email. It's a Gmail, correct?
Yes.
Okay, I'll go ahead and forward that to you.
All right. Thank you, Gemma.
Thank you, Arlene. It's a pleasure knowing you.
And hopefully I'll see you again.
Yes, of course. We have more classes coming up this week and next week. Next week, we're having a tour with MOLA, the Museum of, I know the name of it, but we're having an exhibition about the Oaxaca Californians. So that'll be interesting too. If
Okay.
you could just join us.
Okay.
All right. Other than that, thank you, everyone.
Okay. Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you, Hema.
Thank you, Mr. Bailey.
All right.